it's a great pleasure to ask Alistair Hodgson, Partnership Improvement Officer for the Scottish Centre for Telehealth and Telecare Joint Improvement Team, to come and give us some aspects of what they're doing in Scotland. I know they're doing some amazing things in Scotland. Some of it is in pilot stage, but some of it is actually mainstream now. And these are some of the things that we need to take on board, because they could potentially offer us some of the solutions that we can take forward in Kent. So, Alistair.
Yes, thanks very much, and thanks for the invite today. I know I was in, speakers were introduced earlier on as national and international, but as a representative of the Scottish Government, I'll say that I hope I can be invited back as an international speaker in the future. Or not. So, telehealth and telecare in Scotland. Telecare in Scotland has been around for as long as it has been in Kent. It's certainly nothing new. But where the integrated aspect has come in is probably the last 2 or 3 years when we actually decided to merge the delivery arm at a national level between telecare and telehealth. So the learning from telecare that we've taken has very much been introduced into how we're delivering telehealth now. So I'm just going to quickly run through a few context slides of what the situation is like in Scotland before I sort of talk about the actual aspects of telecare and telehealth. So we have 32 separate local authorities and 14 regional health boards, a bit like your health trusts. But by April 2015, when we go through the process of formal legal integration, that will be split into 32 health and social care partnerships, which will cover all community care, social care, primary care, and some acute services. In Scotland, we have around about 5.3 million people will rise over the next 20 years, much in the same way it will rise down here. Population of over 75 will increase fairly substantially, and multi-morbidities will become an increasingly complex area of need. And crucially, I think the number of people with dementia will double over the next 20 years or so. And actually, the rest of my presentation will focus largely on dementia care, especially as next week the UK are hosting a G8 summit on dementia, so it has got international recognition as to the needs of it. And as you see, you know, the fact that we're all living longer is not unique. It's happening everywhere. But even though we are getting healthier in Scotland, that's not every day. We are still pretty much the sickest nation in Europe, alas. And our sickest nation. But the challenges are exactly the same in Scotland as they are everywhere else. So what are we doing to actually try and overcome these? Public service reform is probably the biggest area on a collective basis, but within the health and social care arena, then integration from a legal perspective is the main driver. And in advance of that, we've had a program called Reshaping Care for Older People, which kicked off in 2011 and is actually a 10-year transformational program aimed at redesigning the way we deliver care for older people. And the one aspect that I think has probably been quite revolutionary is it's not just health and social care sitting down to redesign these services, but crucially the third sector and the independent sector as well. And as part of that, we have actually had a change fund, which I'll come on to in a little bit. But we go on to public service reform. I think the key aspect of this is around integration, but it's also around improving performance and increasing use of digital technology. It's not just in the health and social care sector that we need to be using these technologies better. It is in the wider public sector. You know, there's no point in having fantastic access to our health services if we still have a very, very old-fashioned model in terms of accessing our housing services, for example. Everything needs to be seamless, online, at the touch of a button for the end person, the end user, the citizen. It should be at the heart of everything that we're trying to do. Now, the integration that we're going through is Public Bodies Joint Working Scotland Bill, very snazzy title. Integration does not exist in the legal terminology. It's all about improving the well-being of citizens and the recipients of care. And the key aspects of that will be formation of health social care partnerships, as I mentioned, which will be joint and equal, accountable and responsible to both the NHS and the local authority. And perhaps most importantly, they'll have an integrated budget, a proper integrated budget, which, as I say, will cover all primary community health care and some acute care. and it will be driven by outcomes at a national level. Now, the Reshaping Care programme I talked about, which is for older people, integration that we're doing in Scotland is for all adult services, but we've kind of trialled it, if you like, with older people in advance. And it was supported by a £300 million change fund, which we're approximately 2/3 of the way through. And in order to access that change fund, local areas had to come up with plans for how they're going to redesign services, and those plans had to be signed off by the third and independent sector as well. They could not get access to money if the third sector and care homes and private sector providers were not on board with how health and social care was going to be reformed in that local area. And then post-2014, when the Older People's Change Fund comes to an end, we'll have an integrated care fund for all adult services, which we haven't quite finalised how that's going to be administered yet, but we will continue in funding at a national level. So telehealth care. I have a few copies of our delivery plan with me today if anybody wants a copy of it. But this is, we believe, the first one in Europe to actually have a dedicated plan for both telehealth and telecare, rather than two separate areas going off in different directions. Our objectives, as you can see, are quite clear. We want to expand the use of it, but crucially, for me, I think the most important part is the second point. It's not just us going, here's your equipment, get on with your lives. It's actually training and getting people to proactively demand that they want the equipment in the first place, that they recognize that having this in their lives will actually fundamentally improve their lives. Because we see that there's a clear need to move towards more anticipatory and preventive approaches, such as the use of telecare and telehealth, and more rehabilitation, more reablement, and the greater use of technology is absolutely crucial, I think, to achieving our ambitions. I'll just put this into the slide just because I realise, having been to a few of these European visits, that actually, even though we talk about telehealth and telecare, everybody does have slightly different definitions of what they mean by telehealth and telecare. So in Scotland, telehealth is any health service delivered remotely, and we include telemedicine, video consulting, and also telecoaching, teleeducation. We'll include all of that under the umbrella of telehealth. Telecare is all your care services, and rather imaginatively, telehealth care is both. So around dementia, in Scotland we have our national dementia strategy, and as part of that we have a guarantee for 1 year's post-diagnostic support. So no matter where you are in Scotland, you're guaranteed to have a minimum of 1 year's support post-diagnosis. However, only about 64%, an estimated 64% of people with dementia have actually received a diagnosis. So there's still a significant amount of work to be done in that area. But we want to involve people and their families in actually how they design their care, and we actually want to look at people being equal partners, but not just at home, but also when they're in hospital or in care homes. So at home, how are we looking after people at home with telecare? We commissioned a report by the York Health Economics Consortium in the middle of 2012, and this report was actually published at the beginning of this year. Because we sort of recognised that there was actually a bit of a lack of information or robust information around the effectiveness of telecare for people with dementia. And we chose Renfrewshire because roughly 10 to 15% of all their clients receiving telecare had had a diagnosis in dementia, so they had a strong enough client basis for us actually to carry out the research. And it was fairly standard equipment they had, but mainly door contacts and a standard responder service, quite similar to how it works in Kent. Now, there's a slight typo in this, as people do not tend to stay in a care home for 6,000 days. It's 606 days is the average length of stay in care homes as a result of being admitted from dementia, and 19.5 days in hospital. And as you can see, with the cost that we have in Renfrewshire, the average saving was £2.8 million over 5 years, or just over £8,500 per client. So we've shown that it's safe for users and the staff, it's effective, both the equipment has worked, we've never had any problem with it. Responder services are always able to respond as and when needed. As a result of actually having an increased number of people with dementia receiving telecare equipment, we also increased the profile of telecare, and more GPs in particular became aware of this as a potential option for keeping their patients in their own homes rather than suggesting that they get admitted to a care home. So as you saw in the previous thing, we actually managed to keep on average people out of a care home for almost 2 years as a result of being with dementia. This slide has not worked at all. However, I included it so that if you look at the slides afterwards, it just goes into a bit more detail about the individual report findings. If you don't have time to read the report, then you can look at the slide and it'll see the individual, all the actual key parts of it. But if they do have to go into a care home, we recognise that they cannot just be abandoned. So we have an all-day psychiatry telemedicine clinic being trialled by NHS Highland. This is in Abbeyfield, Ballachulish, where remote and rurality is slightly more stark than it is down here. At least 2-hour drive to get to the nearest hospital from this particular care home. And as anybody who knows who's ever dealt with anybody with dementia, they're not exactly in the most coherent state anyway, but sit them in a car for 2 hours and they're going to be even worse. So by the time they actually see the clinician in the hospital, they're far, far worse state than they ever are in the normal habitat, if you like. So we think, well, how do we actually see them in a better environment? We use video conferencing. Not rocket science, but as most of you will know, it's not also the easiest thing to get clinicians on board sometimes, these things. So we didn't just pluck out of thin air. We did actually find some evidence to show that this sort of worked. So what do we actually do? Well, anybody can be referred to this service, not just people with dementia, it's any psychiatric region. As it turned out, everybody who has been referred has had dementia, but we're not limiting it at dementia. If the equipment's in there, why would you limit it to one particular client group? And it's a nurse-led clinic in the hospital, although it is overseen by a consultant psychiatrist, but it is a nurse specialist that the patient will interact with on a day-to-day basis. And the service is run for 2 hours every week, twice a week rather. And each individual will speak to the nurse for 5 minutes or the whole 2 hours. It just depends entirely on the need. It's not set times, it's literally an iterative process, which is entirely fluid. And if there's a need for a longer conversation, they will have a longer conversation. So even though it's for 2 hours, sometimes the whole clinic might run for 5 or 6 hours if there's a particular need for it that day. And it's not just the patient to clinician, it might also involve the care home staff, it might involve the family, or it might involve the GP as well. Sometimes the GP will come into the clinic and actually sit in with the patient and talk to the consultant or the nurse specialist in the hospital. But every 6 months, the specialist will come down and visit. So far, we've had 10 patients involved, 8 referred. 8 referred because of the behavioral and psychological symptoms of dementia criteria that are used, and 1 was picked up because of antipsychotic behavior, and 1 was transferred to another clinic. We successfully managed to withdraw 2 from antipsychotic medication. 2 have been managed solely with behavioral plans. 2 admissions have been estimated to have been avoided. As you can see, we can't put a completely robust figure against that, but we do estimate we've saved, purely in those 2 admissions alone, over £40,000. So you can see the potential if this program becomes widely available. And the 1 person that was admitted was probably admitted later than it actually would have been if it had been a standard service, if you like. So this sort of standard approach, if you like, is there's 86-year-old with dementia, severe dementia. She's had very classic symptoms of uncontrollable behavior, if you like. She would traditionally have been admitted to hospital. In fact, on 1 occasion, even though we had VC and she had happily used it in the past, she decided to attack the VC unit. So without her in the room, the actual staff in the nursing home then sat down with the nurse and the consultant in Inverness and actually went through an entire program of support for that woman. It meant that the staff themselves in the care home, their own training, their own knowledge was significantly uplifted. They were given extra information, extra training, extra local contacts they could call upon, and then no additional medication was needed. Her symptoms became managed in a better way, and ultimately she was able to die at home rather than, or near her home, instead of 80 miles away in a specialist dementia ward. So NHS Highland have been very, very impressed with the findings of this. So much so that they've decided to increase it to another 2 care homes. One, as you can see, is an even more arduous journey to get to Inverness, so actually sticking it there makes even more sense. And also NHS Lothian are now interested in putting it into some of their care homes, or rather care homes in NHS Lothian, not run by the NHS. And NES, who are the national education for the NHS in Scotland, are now looking at testing in community hostels as well. And one thing I would say as well, actually, the pictures I set out at the very beginning, one of them was our Cabinet Secretary going to see the service, and as part of that visit, the Chief Executive of NHS Highland actually came and saw the service for the first time herself. Now, as a Chief Executive, she was obviously aware of the service existing, but she was a big skeptic. She let it happen as a trial basis, but until she actually saw it herself, she didn't believe it would work. And then just seeing it with her own eyes, she actually became a big believer in it. So don't just forget about trying to engage your clinicians. Sometimes it is actually letting the top management actually see these things for themselves rather than being given a bit of paper that tells them what the impact is. So where do we see this going in the future? As you say, depression is massively underdiagnosed in elderly patients, particularly those with cognitive impairment. There's not beyond the wit of man to train up special care home staff, but also community nurses, community hospital staff, in recognising the signs and be able to refer them to the appropriate clinician through use of video conferencing. NHS Highland are scoping the potential for expanding it throughout their entire region using teams of nurses, whether it's community nurses or ward nurses, with medical support provided to pretty much every single care home on what is a fairly vast and challenging geographic area. And ultimately across Scotland is looking at, see where, as I was talking about the NES paper, whether we can involve community hostels in the long run. So I don't want to take up too much more of your time. I'm happy to take questions later on in the day. I'm just going to finish this by saying Edinburgh's beautiful. Do come and visit. Okay, thank you.
Thanks a lot, Alistair. That's great. I mean, I think that it's really important for us to understand how we try and get people supported in their own home. I think that's really important. There's various things twittering around, but how we manage to reduce antipsychotic treatment. Also that we've got Bruce Pollington here, who's our teleconferencing expert. And how do we upscale these things? Because although Scotland's doing some great things there, how can we make this really happen? And in fact, there is quite a lot of isolation in Kent. Even if it's just about trying to get onto public transport, it's pretty difficult, let alone people being imprisoned in their own care environments. So I think all of this is a way of empowering them and using technology to do that differently. So